Good evening, everyone, and thank you so much for joining us. On behalf of the president of Alpha Kappa Alpha Sorority Incorporated, Xi Omega chapter, and our over 660 members, we welcome you here with us this evening for this webinar. Women of color have a 50% greater risk of developing cardiovascular disease than other groups. Alpha Kappa Alpha has focused our women's heart health program on women with cardiovascular disease, hypertension, and high cholesterol, and all risk involved. There is now special emphasis on not only educating the community on cardiovascular disease, but also on type 2 diabetes. The American Heart Association and the American Diabetes Association's initiative, No Diabetes by Heart, aims to empower people living with type 2 diabetes to lower their risk for cardiovascular disease. We now have a third piece to consider, and that is COVID-19. Our panel this evening will enlighten us all on the importance of knowing our risk and maintaining our health against all three diseases. I will now introduce our moderators for the evening. Ms. Tanya M. Brown is a native Washingtonian and the target lead for Xi Omega's Women's Health Care and Wellness Committee. Diane L. Johnson is a retired business management executive with experience in the day-to-day operations of a $10 million information technology company. Both of these women work very closely with Monday Activities, Xi Omega's longest running program for senior citizens. I will now turn you over to Ms. Tanya M. Brown and Ms. Diane L. Johnson.
Good evening, Nicole, and good evening, everyone. It is my absolute pleasure to introduce our first panelist, Dr. Kelly Taylor. Dr. Taylor is a senior researcher in the Institute of Global Health Sciences and Director of Community Engagement in the Pandemic Initiative for Equity in Action at the University of California, San Francisco. Her work focuses on eliminating health disparities in marginalized and underrepresented communities. Her current projects focus on vaccine communications and using virtual reality to allow providers to walk a mile in the shoes of patients of Black and Latinx backgrounds as they access healthcare. The intervention aims to improve healthcare delivery and patient-centered care by creating empathetic patient-provider relationships. Welcome, Dr. Taylor.
Thank you.
Diane, you're on mute.
I'm so sorry, technical difficulties. Tell me this, would we like to start with more questions or questions to Kelly, or should I do an introduction of our cardiologist?
I'm open to whatever decision you make. I can absolutely follow your lead, Diane.
Well, let's introduce Dr. Shea Bolarunduro. Dr. Bolo, to his patients, is an interventional cardiologist with expertise in cardiovascular diseases, clinical research, and global health. He practices at Inova Fairfax, Sentara, and Mary Washington hospitals in the DC metropolitan area. Dr. Bolo graduated valedictorian from medical school and received his master's degree in public health at Johns Hopkins. Residency and fellowships throughout the United States followed. Dr. Bolo is multiple board certified in 5 cardiology disciplines. He's authored more than 40 manuscripts, winning many research awards in the process. Dr. Bolo is passionate about excellent patient care, eliminating healthcare disparities, physician mentorship, and pipeline development. Dr. Bolo pursued a career in interventional cardiology to combine direct one-on-one patient care with global health in a field that is the leading cause of mortality in the world. Welcome, Dr. Bolo.
Thank you very much. It's great to be here.
And our first segment this evening will feature Dr. Kelly Taylor, and we're going to talk about the science of COVID-19. Dr. Taylor As an epidemiologist, are there still trends that show Black and Brown communities are still more affected more by COVID-19?
Yes, they're definitely more affected by COVID-19. It's a trend that spans many disease processes and diseases. Some of the most familiar, and we'll talk about tonight, are diabetes and cardiovascular disease, and COVID is no different. And as Dr. Bolo will talk about probably more along the lines of why that is in terms of the medicine and science, from an epidemiological standpoint, we focus on the social determinants of health that impact our Black and Brown communities more than they impact white communities. And so folks may have heard of the social determinants of health, and it really is centered around the conditions and environments where people live, work, and play, and the increased risks in those environments and because of those environments for Black and Brown communities. So there are things like the wealth gap, healthcare access, food apartheid, and other influences that affect the risk and quality of life outcomes for Black and Brown communities.
That's really interesting. And can you elaborate on the component of food apartheid?
So we made, it used to be called food deserts. It was, and it still is in many spaces. But what we recognize is that, this is an intentional and structural issue for our Black and Brown communities. Why there are there's fewer access to healthy foods. What has structurally and historically disenfranchised communities of color, and how we've ended up, because of redlining and other structural issues, such as systemic racism, have led to why Black and Brown communities are less healthy. And so apartheid being a system that is imposed upon folks, that these communities don't have access to Whole Foods, Trader Joe's, and other, not to call out specific brands, but what people generally are often associate with healthy food access is why these structural determinants of health, and food apartheid being one of them, are reasons why Black and Brown communities don't have access to healthy food.
Thank you, Dr. Taylor. And our next question is, why is there still increase in the rate of diabetes despite all of our advanced knowledge and medical technology?
Yeah, so, there are several reasons why, we're at higher risks of diabetes and why it's sort of intractable in our communities. I think the issue is complex and multifactorial, but there are issues around our aging population. We're not getting healthier, as we talked about with food apartheid and not having access, but as a community in general, and internationally and nationally, we're not necessarily getting healthier. We even see this in our international communities when we often say, I do work in international health spaces, and we've exported America's failures, like McDonald's and other unhealthy food choices. But the other reasons are we are diagnosing diabetes at earlier stages. We're having pre-diabetes screenings. We have tests that are easier to diagnose diabetes, and you don't have to, the fasting glucose blood tests that a lot of folks are used to having don't have to be used. You can get your diabetes test results much more quickly than you have been able to in the past. And then, like I said, with the aging communities, as you age, there are increased risks around diabetes. And so with longer lifespans, coupled with sedentary lifestyles and unhealthy food choices and sedentary jobs that we have, we often see the increases in diabetes, not just among Black and Brown communities in the United States, but globally. We're seeing this rapid rise and increase of diabetes in many communities.
Thank you, Dr. Taylor. And the question that everyone wants to know, Dr. Taylor, is when is COVID going to be over?
So I think what we've learned from many gaffes and hiccups with regard to predictions about COVID is that we are reticent to say when COVID's going to be over. What we do know is that COVID is probably here to stay. And what you may hear in some, the language that we throw around as scientists are pandemic versus endemic, et cetera. So what we're seeing is that COVID is getting to a place, hopefully, I mean, we'd love to see it disappear completely, but that's just not realistic. We're hopefully moving towards COVID being endemic, which means that it'll be around with us. It'll coexist with us, and it'll crop its ugly head, maybe worse or better, and depending on geography and populations. But what we'll end up doing is learning to live with COVID like we live with the flu. And, in global settings, some places like, for instance, malaria is endemic. It's something that is kind of ever present. And we learn to adjust with things like vaccinations and prevention efforts for, myriad diseases. So that's probably the path that we're going to see eventually with COVID. But right now, we're still trying to get people vaccinated and boosted and keep everyone safe so that although we probably are going to end up with it endemic, that we won't see the high mortality and morbidity rates that come along with COVID.
And you mentioned vaccination and boosters. Can individuals who have received a booster shot schedule another booster within a certain time period?
Yes. So you may have seen as recently as yesterday the new FDA guidelines about getting your fourth booster shot. And folks are often confused about, who gets boosted, when you can get boosted, et cetera. But if you've received your first set of vaccinations, so that's 2 doses of Pfizer or Moderna or the 1 shot with J&J, you can get your first booster within 5 months. And then the fourth booster shot, which they're recommending for people over 50 and those who are immune compromised, you can get that now within 4 or post 4 months, your last booster or your second or third shot, depending on what you got before. But they are recommending everyone who can get that first boost, that third jab or second jab, get that. And then for those who are at high risk, start scheduling their fourth booster, because what we do know is that immunity does wane, and we don't have enough data points at this point to say exactly how long we're going to be protected, but that additional booster will definitely protect those who are most vulnerable.
Thank you so much, Dr. Taylor. And if anyone has questions for Dr. Taylor that's joining us via Facebook Live or Zoom, please type your questions in the chat or the question and answer segment, and we'll read those questions to her at the end of our webinar. And now I will turn it over to Diane Johnson.
Thank you, Tanya. And it's not if there were questions. Questions were coming fast and furious. And yes, we do want you to know we're going to try to get to all of your questions. But right now, again, welcome, Dr. Bolo, world-renowned interventional cardiologist. And one of your passions is one-on-one patient care. And so before we get into the nuts and bolts of your cardiology work, I want to ask you, in terms of diabetes, African Americans are 2 times as likely to die of diabetes, 3 times likely to be hospitalized, and the statistics go on, and they're all bad. What is it you do as a cardiologist? Because there is a link between diabetes and cardiology, but what is it you can do with your patients to help them understand what they must do to help themselves before they're into full-blown diabetes?
That's a great question, Diane. I like the fact that you said before they're into full-blown diabetes, because I think that's where we really want to start from. We really want to start from the cradle, the healthy choices that we make right from when a kid is born, before we start trying to deal with complications, before we start trying to deal with, okay, we're struggling with this now. We have high blood sugars, we have complications of diabetes. The point is, what kind of choices are we making with the kids right from the beginning? So I have 2 daughters, okay, 7 and 4. And then when we talk at home, it's like, okay, well, I would rather, they want to have fries, they want to have ice cream, they want to have this, they don't want to have the vegetables. But then how do we, in a cultural context, what do we eat at home? And when you start with the fact that you're making choices that influence you, bearing in mind that what you do influences your kids and their selection, all through life, that is the first step. The first step, like you pointed out, is before you get diabetes. So what kind of healthy decisions are we making at home? What are the kids being exposed to? What are they going to eat for breakfast? What are they going to eat for dinner? Yes, I know we get busy. I know cost of healthier options are much more expensive. But all those factors come in so that we make the family make healthy choices. So then the kids get comfortable saying that I love my vegetables because dad eats his vegetables, mom eats the vegetables, and so we do the same thing, and we have a culture that goes on, and that culture perpetuates itself all through life. So it starts from the cradle. It starts from those choices that we make. Then it goes to, when we're in school and everything like that, going through teenage years and all that, kids are active, kids exercise, kids make healthy choices in terms of, okay, well, I like to play basketball, I like to play, football, I play whatever I want to play. But there's some choices that we make sure that our families members make to ensure that they're doing the right thing long term. And then when it now gets that, but the change tends to happen for some people when they get into, when they get to their 20s and their 30s, where they're not in structured environments. You're not in high school when you have a team sport. You're not in college where you have a team sport or you have some activity or friends that you hang out with together and you go play a sport. And then you find out that, well, those changes begin to happen, and then we begin to make decisions that catch up with us. So I think that's where it starts from. It starts from, I have this conversation every day in the office. I have this conversation every day when a patient has a heart attack, and then we've just gone in there and we've put a stent in, the heart attack is taken care of, you're alive now, and you're good, you're gonna stay good, but we need to make healthy choices. But you've already spent the last 40 years, the last 50 years making unhealthy choices. So now you need to have a deflection and then come up to a point and say, okay, now I need to make changes. But I would say the best thing to do is make those changes from the beginning. Many of us here are at an age where we're raising kids. And so actively making those choices with our kids so that they don't have to deal with those bad risk factors that you talked about. Because like you said, twice as likely to affect African Americans at a minimum, and then the risk goes up higher in different segments of the population. So that's just something I want to bring up and then emphasize the fact that it starts from the cradle.
One more question on diabetes, and then I want to jump into your cardiology practice. Does diabetes put you at higher risk of death if you catch COVID?
Diabetes alone puts you at higher risk from death from anything. Okay, so coronary artery disease is when you have blockages in the arteries of the heart. So your heart's not getting enough blood flow. And we think about that a lot when we think about heart attacks. Oh, you have coronary artery disease and it makes you at high risk of having a heart attack. For a longest time, the major thing that we used to have in the cardiology community was thinking of diabetes as a coronary artery disease equivalent. The risk of diabetes alone is almost as bad as having blockages in your heart, just diabetes alone. Okay, so in terms of when we're talking about risk factors, diabetes is such a strong risk factor that now we know it's slightly less than coronary artery disease, but we know it's almost as bad as coronary artery disease. So we call it like a coronary artery disease equivalent. So it is a big factor in terms of your risk of dying from anything. So when you now have COVID, you already have a poor immune system from diabetes. You already have complications building up from diabetes affecting multi-vessels, your brain, your kidneys, your heart, every part of your body. And then you now have COVID, which is also a multi-systemic disease affecting all those areas. Your risk is already high to begin with. Patients with diabetes do not do well. So I know we talk about obesity, we talk about smoking and all that, but diabetes is a very strong risk factor that predicts poor outcomes in COVID patients.
Now, what are the most common cardiovascular diseases in the African American community?
So the most common is high blood pressure. It's the most common risk factor that we have. Like you mentioned, diabetes, tobacco abuse, obesity, are the most common risk factors. Depends on the age group, depends on the demographic. You find out that many people are also not as active in terms of exercise, and then we have a sedentary lifestyle. And those become risk factors, high cholesterol. They become more important risk factors as time goes on. You know, the major point is in women, and I want to say this because in African-American women, there are some underestimated risk factors. You know, we think of high blood pressure and we know that, yes, it's bad. But many of us do not think about the fact that preeclampsia, which is very common. If I was going to talk to a group of African-American ladies and I said, how many people have had preeclampsia in pregnancy when they were pregnant, I would have a high number of people raise up their hands. But people assume that that's gone with pregnancy. But no, that is an increased risk that puts you at a higher risk of heart failure long-term in life, and definitely puts you at higher risk of hypertension in the long run. So there are many risk factors, some of them more recognized than others, but it's important to bring this up and then emphasize them, you know, during our assessment of, you know, ourselves and our families in terms of their risk factors.
One of our participants put in the chat, and many of them are preventable.
Yes.
That's the sad thing. We can help ourselves a little more than we are doing. Are some of these diseases hereditary? And if that's the case, what do you do?
So many of them are hereditary. But like we talked about, you know, there is a role for hereditary based on just the fact that your parents pass it on to you. But there are also social determinants here where, yes, your parents have this and they give you that risk, but we have multiple hits. You know, it's a multiple hit model. There's the hit of the genes, your HIT, where the genes hit you, but you also have the decision-making process of how we live our life based on how our parents live their life and how the decisions that they make. So it's very important to understand that, yes, we have these risk factors because they come to us because our parents had them, but we also have a major role to play in terms of dealing with those risk factors. So it's a bit of both.
Well, and again, because it is hereditary does not make it any less serious. You still have to deal with it.
Yes, very important.
In your medical practice, have you seen a number of more serious cardiovascular cases because of COVID?
Yeah, so I'm an interventional cardiologist. So what does that mean? It means that when someone has a heart attack and their EMS is called, they're bringing them into hospital, they're thinking they're about to die. If you have an EKG that shows an ST elevation myocardial infarction, which is the bad heart attack, I'm the person that they call to come in to address that. So we're coming in, we're doing an emergency procedure to go into the arteries to restore blood flow to the heart, and then, you know, hopefully get the person, you know, for most cases, of course, get them home to their families, eventually live a normal life. One of the things that we saw when COVID started was there was a higher incidence of sudden heart attacks like that, where you have blood clots. We know COVID causes blood clots, but most of the time we think of the blood clots in the lungs, but we don't think of it as affecting the heart. So we had a lot of cases that would come in that kind of a scenario, and you go in and you see blood clots everywhere in the heart and all of that. And COVID definitely increased their risk of heart attacks. Those were the more classic, you know, really traumatic ones because they were really difficult to treat and they didn't do as well. Of course, COVID causes a lot of other things. The most common thing everybody talks about is myocarditis. So myocarditis occurs in 15% of patients who have COVID, but 15 to 22% depends on who you're quoting, depends on what data you're quoting. But the question is, how clinically significant is that myocarditis? For some people, they will have some of the chest pains and they will have some symptoms that will make us investigate it and find that they do have myocarditis. But for many people, that population of the 15 to 22% of patients who have higher burden COVID that have that are patients that are found on MRI studies. So studies that actually like do MRIs on patients who have COVID and then do like there are two studies that are very popular. One of them is a study on athletes. And then there was the other German study, which basically took patients who had COVID and were not admitted to the hospital, then took similar matched patients who had COVID and were admitted to the hospital, and then were sick enough to be admitted to the hospital. And then took another population of patients who did not have COVID but were equally sick, and then did MRIs on all of them in their chest to see how they assess their burden of myocarditis. And of course, we saw that there were higher burden of myocarditis in patients who had COVID and then were sicker than those who had COVID and were not sick. And those who had COVID and were not as sick were definitely even higher than those who did not have COVID but had other risk factors. So we think of myocarditis as a major risk factor, but and then there are other things that COVID could cause also. It could cause arrhythmias where your heart beats out of rhythm. It could cause patients having chest pains, could cause them to have, heart failure. COVID on average reduces, can increase your risk of heart failure. So many of those things are things that we're seeing now. Every day, we see patients come into the office talking about, oh yeah, since I had COVID, this is what's going on. Since I had COVID 6 months ago, 1 year ago, I haven't been myself. So yes, it does contribute to this, unfortunately.
Earlier in the program, we asked Dr. Taylor, when is COVID going to be over? And basically her answer was, it's not going to be. In some form, it's going to be here and we're going to learn to live with it. In everyday terms, what do you tell your patients who have heart problems, may or may not have experienced more advanced heart problems because of COVID? How do they live the rest of their life? What should they be doing?
Yeah, so, the first thing I tell my patients is, if you're not vaccinated, get vaccinated. Unfortunately, every day we talk to patients or patients' families who, for different reasons, choose not to get vaccinated. Every medication in the world has side effects. Tylenol is taken every day, but it has side effects. Everything has side effects. So if you focus on the side effects and you forget about the benefits it gives, then we tend to not do as well. So that would be the first thing I would say. The next thing will be, yes, the pandemic is not as bad as it was in 2020. The mortality rates are not as bad. We are better in taking care of these patients. But for some patients, they still have it as bad as we did in 2020. So you don't want to be that person. Every day I see a patient who unfortunately has a story that I could tell you stories of patients I saw today. I mean, you don't know them, you don't know where I am. So it's not HIPAA, you don't know, but I could tell you people who, lady just came in today and then she's not been herself for 6 months because she's not been able to breathe and she's not been able to do the things that she can do. And then she's debilitated and she hasn't gone to work for 6 months since she got COVID. It's not just her, multiple other patients who had COVID with an underlying heart problem and they've just not been themselves 6 months, 9 months later. Just today alone, I could count 5, and then COVID is the background thing. So COVID is bad. So no matter how much better things are getting, we need to remember that for those who get it, it could be really bad and it could be really debilitating. So it's important to get vaccinated and then still make the informed, healthy choices that we used to make before. I still wear my mask when I go into public places. I still try to be as safe as I can in many of those places. I still wipe my hands in between contacts, still try to make some of those choices that we made last year and permanent. But yes, it's going to be difficult.
You've put this in a lot of perspective because I think a lot of people have begun to think, oh, it's better. But when you say you saw 5 patients in one day that COVID has affected their heart, because that's why they'd be there to see you, we're still dealing with a lot.
Yeah, we are. And we are going to, like Dr. Taylor mentioned, we are going to be dealing with this long term, so we don't want to get, to be complacent and say, look, this doesn't matter anymore. We can do whatever we want to do. We still want to take it seriously.
I'd like you to kind of sum up for us when the name of our program, Know Your Risk. Tell us exactly what each of us needs to know to make sure we keep ourselves as safe as we possibly can. For those that have pre-existing conditions, to manage those conditions as effectively as we can, so that we can take care of our bodies and get back to some semblance of normalcy.
Okay, that's great. I like the title, Know Your Risk. The American Heart Association has a similar promotion, which is called Know Your Numbers. And then, so know your risk, know your numbers, very important, okay? You wanna know, one, what's your blood pressure? So what's your average blood pressure? For most people, we don't have a blood pressure machine at home, we don't check it. But you should, especially if you're, definitely if you're above 40 years old, you should have a blood pressure machine at home and you should have an idea of what your blood pressure numbers are. Know your cholesterol. Know your LDL, which is normally called the bad cholesterol. Know what those numbers are. Know your HDL, your good cholesterol. Know your triglycerides, okay? Know your hemoglobin A1C, which is a marker of your diabetes status. Know your BMI. Your BMI is your body mass index. So these are like very important risk factors that we need to know. So your BMI should be less than 25, right? Your blood pressure, goal blood pressure, which is ideal, will be 120/80. We want an LDL less than 100. You want an HbA1c less than 5.6. So those are some of the things that you want to know. You want to know what's in your food. Okay, what am I eating? How much calories am I taking in? It might take, you could get a class, or you could just go on YouTube and then educate yourself. You don't have to pay for many of these things anymore. You could just go to the right place and you could get a video and listen to it. We spend so much time on Instagram and then on Twitter, we could actively one day educate ourselves on some of these things. So, know that you need to have 30 minutes of exercise a day with a goal of 150 minutes of exercise a week of moderately strenuous physical activity. So know how much alcohol you drink. So some of those things are like important things that we know. But it's important to see what our risk factors are, because the CDC recommends that you take, for women, you take 1 drink or less a day for a woman on average. That's a drink is considered like a cup of wine, just 1 cup of wine a day. So, or 1 can of beer. So if you say I drink, I take this amount of alcohol, then you're taking too much, and then you know that you are having higher risk factors. So if you say I take more than a glass of wine, you are taking too much wine. Or I take 2 bottles of beer, that's a little too, more than 12 ounces of a 12-ounce can of beer. That's too much. So there are a lot of risk factors that we should know. We could start from the basics and then just know those numbers and then try to work on getting there.
You have given us a lot of food for thought, because I would wager there are not many of us on this particular program that can tell you all of the numbers you mentioned. I know I certainly can't, and I consider myself kind of sort of being healthy. So good advice. One final thing, a lot of people, because of COVID, stopped going to doctors for their annual checkups. The last time I went to have a mammogram, the technician said to me, "Now, did you do this last year?" I said, "Absolutely. I mean, I was masked up and I had my personal air purifier around my neck, but I was here." She said, "You would be surprised how many people stopped coming for their annual checkups because of COVID. Yes, we were afraid. Yes, it was dangerous to be in crowds, but you still have to do your health things."
Very, very important, yes, because many people did forget to do that. And unfortunately, we have we see the result of that in terms of prevalence of diseases right now, or rather the incidence of new diseases that we're catching up. We're finding out a lot more patients being discovered with breast cancers that are more advanced than they should have been, coronary heart disease that are more at later phase. We found out during the height of COVID that many patients were coming in with bad heart attacks that because they've been sitting at home dealing with the chest pains and just not refusing to get checked out and then waited until late. I think right now, since we are already at a place where most of us are back to our usual activity, we really don't have much of a reason not to go seek out healthcare at this point. We really don't. I mean, we're in the mall, we're back in the movies. We should be seeing our doctors.
I think you're right. Well, Tanya, how about we go to the audience and start taking questions? I watched the chat and there were lots of questions rolling in for both
Yes.
Dr. Bolo and Dr. Taylor.
Absolutely. So thank
Tanya?
you, Dr. Bolo. Yes, Dr.
Before
Taylor.
we get started on the Q&A, I wanted to add another point that Dr. Bolo may want to address, is that what we also see is, and what we don't know, we see that folks that you may hear of long COVID or long haulers, people who have post-COVID symptoms of various types. What we don't know is how COVID is going to impact our bodies long term. So some of these things that we're seeing emerge for folks, we don't know how that's going to affect your heart and other diseases that you may have or may be predisposed to. So in tying in with seeing your doctor, the other reason to get vaccinated is because if we can prevent you from getting COVID, you may not see some of these impacts that we have yet to really discover and understand. We're still learning that. And I'm sure Dr. Bolo has seen patients come in his office with undescribed or other symptoms and ailments that may or may not be COVID related, but we just don't know if they are and what that's going to look like for folks long term.
Definitely, I definitely agree with what you're saying. Yeah, we don't know, but we know that getting vaccinated reduces your risk of having COVID and definitely reduces your risk of having long COVID. So, because if you get COVID, if you're vaccinated, the burden of COVID is less, and then so even if you get it, you're less likely to have the long COVID.
Thank you so much. And Dr. Taylor, the first question is for you. Can you explain to the panelists the new BA.2 COVID strain just announced and the difference from the original COVID or Omicron COVID strain?
Sure, thanks, Tanya, for that question. So what we know about viruses, all viruses, is they can mutate or change. That's why when you hear about getting your flu shot, they may say it may not protect you from the current strain, but it could be protective or reduce your symptoms from the current flu viruses. And so the same thing with COVID, it mutates, and it could be a new strain or a new variant or a subvariant. So what we know about BA.2 is that it's a subvariant of Omicron. So there's a little bit of a difference in the spike protein, the way it mutated to become a sub-lineage or some variant of Omicron. What we also know is that it's highly contagious. It's emerging as the most prevalent subvariant or sublineage in many spaces, including the United States, but it also is not causing severe disease like we've seen with Delta. So people aren't necessarily getting sicker, but we are seeing that people are, being diagnosed with the new subvariant or sublineage of Omicron.
Thank you.
I was going to tell Dr. Bolo there's a question. Dylan Hammond says, I know that we are talking generally in regards to diabetes type 2. However, what information or advocacy could we do to educate our communities more about juvenile diabetes type 1?
That's very important because the juvenile diabetes type 1 affects it's more common in younger patients, but the burden is higher in the sense that these kids start having the effects of diabetes from a younger age. So they start seeing complications at a much younger age. That's when you see patients who are in their 20s or in their 30s having heart attacks and then having, major complications, diabetic gangrenes, diabetic ketoacidosis, that it could potentially be terminal. So it's definitely important to educate patients about and families about this. Working closely with their pediatricians. If you have a kid who tends to be, sick a lot or tends to throw up, we want to make sure you're getting care, because many times you don't always think about that initially. You're not thinking, oh, maybe this kid is going to have diabetes type 1 when he's 7 years old or 8 years old. But if a kid is not doing well, we want to be quick to seek medical care and get the information about that kid, and then start working actively in terms of to control the risk, to control the diet, to control what the kid is exposed to educate the kid more about, okay, well, every other kid might be doing this, but you're different. And then, and so, it's not easy, but it's definitely important. And then, like they say, it takes a village. It takes everybody around. It takes the parents, the uncles, the aunts, the family members, the school, the teachers, the people who walk around the kid, to know that we want to make you understand that, yes, you are different, but you're still one of us, you're still the same. And then eating differently does not make you any, because every kid wants to feel like part of the group, right? Doesn't want to feel like, oh yeah, all the other kids can have this, but I can't have it. But there is that role that everyone around needs to help make. So I really like that question because it's a multi-systemic involved process where everyone needs to be involved in making the kids learn and then do the right thing.
Dr. Taylor, what is meant by most vulnerable?
So yes, I think one of the participants in the chat also addressed this, but vulnerable populations are those that are generally at high risk of health disparities and other diseases because of some of the structural issues that we talked about, living in poor neighborhoods, access to healthcare, often racial and ethnic minorities, marginalized communities, folks who live with disabilities are some of our most vulnerable, in children with diseases like childhood diabetes, et cetera, are part of those vulnerable populations as well.
We have another question. Can the panelists please explain the new BA.2 COVID strand just announced and the difference from the original COVID or Omicron COVID strand?
Yeah, I think we tackled that one a little bit earlier. But yes, so BA.2 is just a sublineage of Omicron or a sub line of Omicron. And so highly contagious, doesn't seem to make you more ill than, say, for instance, Delta. There's some breakthrough in terms of being vaccinated, but if you're vaccinated and boosted, that you don't get as sick from even the sublineage. But viruses, like I said, mutate and they change. That's what a mutation is. And so you'll see some subvariants will be named and sort of stick around, like Delta, Omicron, and now BA.2. Others they'll name and you'll kind of forget about, or they won't mention because of the impact is low. So when you hear of a new variant that's emerging, and especially if they continue to discuss it, it's because it's likely highly contagious and has a huge impact in terms of health and transmission. And if you don't hear about it or it goes away relatively soon, then it's not as much of a concern, generally speaking.
Dr. Taylor, is it safe to say there are going to be more variants to come?
So it's safe to say there will probably be more variants, whether or not they get a name and make it in the news, or name that we hear. Again, viruses are always mutating, and so what we do know, and I think Dr. Bolo has emphasized this as well, is that if you get vaccinated and boosted, and the more people that we get vaccinated and boosted, the less likely variants are to emerge and thrive. Variants come from, they find a host and they can grow and change, and then they pass on to somebody else. And so that's how we get these variants that emerge and do damage and cause and wreak havoc on our community. So again, the most sound advice is to get vaccinated and boosted.
One participant would like to know, do you have any advice for helping family members with diabetes adhere to treatment? She says, my father has diabetes and does not like taking his medication or taking his blood sugar. What do we do with Dad?
You want to tackle that? I mean,
Oh,
as a behavioral scientist, it's not easy, but I'm going to turn, I can talk about it, but I'm going to turn it over to you, Dr. Polo. What do you
Well,
think?
actually, I was hoping you would take that.
I mean, so we know it's hard to get people to follow medical advice. And I think, my other research area is HIV prevention. And so we take the approach of harm reduction versus shaming, and prevention versus treatment. And so what we like to emphasize patients is that, give them the information, help guide them as much as you can, and hopefully they'll make, better health decisions. People are on a continuum in terms of where they are in their decision-making process, and they ebb and flow. We've seen that with vaccines as well, like people's willingness to get vaccinated. But, I think continuing to talk to your parents and loved ones, encouraging, healthy behavior as much as you can in the households, and, standing behind the person, going to the doctor's appointments with them if they'll allow you. I know even my own partner is resistant to me going to his medical appointments. So, but if you can, just promote harm reduction and good advice, and show up by doing in terms of your own prevention and health and wellness, and try to bring them along with you. Dr. Bolo, do you have any shame? It doesn't work.
I definitely, that's great. Definitely agree with everything you said. This is a conversation we have many times. What I do, because I talk to my patients and I tell them that, look, yes, I'm your cardiologist, but I see myself as your coach. So when I say I see myself as a coach, for most people, they can connect with when they were at some point training for something. You're on track, you do something, you know that your coach is probably going to tell you things you don't want to hear. But your coach wants you to win. And then, so yes, you might go into the game, but you have to put your game face on, and you're going to work with your coach to get to where you need to go. So when I have patients come into the office, and then mostly men who are not compliant, and then they come in alone, I tell them, I'm not going to see you unless your partner is here. So pick up the phone and call him or her, and then we talk. And then we talk on the phone, and then, because when you tell me what's going on, I want to hear what your partner says. And if they disagree, I'm going to take what they're saying, because we have to walk. So basically, it now becomes the part where, we're working together as a team to help you succeed, because we know you want to succeed, but it's not easy. It's not easy to wake up in the morning and run laps around the field. It's not easy to do any of those things, but you get up and you do it the same way. So you did it then. It's not going to be easy to do it now, but get up and run a lap, literally.
Dr. Bolo, and speaking of running laps, and sometimes that stress prevents us from having the energy and the mental fortitude to exercise. However, Amber would like to know, does stress and trauma prevent us or increase our chances of diabetes and heart disease?
Yes, it does. Yes, it does. Unfortunately, stress comes in different forms. We think of stress as, I'm so stressed out, so I don't do the things I want to do or I should do. And sometimes we think of that as a justification. We're all human, so when we're really stressed out, we don't get to do the things we want to do. But that is an incentive for us to try to deal with our stress, to have active measures in place to reduce stress. So which could mean maybe, change that job, maybe do something different, maybe adjust some patterns that you're involved in, because it's really important. Stress itself on its own could lead to a heart attack. We've all heard in different ways of the broken heart syndrome, where you have patients come in to the hospital with a heart attack. They have all the signs of a heart attack. We go in to look at their arteries, and then there's nothing wrong with the artery, but the heart's weak now. It wasn't weak yesterday, it's weak today, because a lady I was talking to, who actually has become quite close to me, and one of my patients, was because her son was going to jail, and immediately it happened. She heard that, she had a heart attack. So she's been dealing with stress, but he had one event, and that changed everything for her heart. And now we have to start trying to get it back into normal. So yes, there are major stressors, and yes, sometimes those stressors may be incapacitating and keep us from doing what we want to do. But we need to understand that stress should not be a crutch. So we can't let stress be a crutch. We have to address the stress, with whatever mechanism you have, whether it's religions, family, meditation, praying, whatever it is, but address that stress so that way you could live the life you're supposed to live.
Thank you so much.
That brings up a question, the isolation that COVID forced so many people into. Did you see an increase in the number of people who had heart problems as a result of the isolation that went on for more than a year?
Oh yeah, definitely. Definitely, there were a lot of cases like that. Unfortunately, unfortunately that was quite bad. And then we saw isolation affect patients in different ways. Some patients, stress-induced heart problems. Some patients who had stable heart problems, who, heart disease tends to get worse as you get older, right? So we have a lot of patients who have early phase dementia, but then they have heart problems, but it's stable and it's being controlled. I have a patient who comes to mind who is an older man, but he's my friend because his sister will bring him in and we would joke for throughout the appointment. But he had dementia, but he would always joke and we would crack jokes about things, about life. But because of COVID, he couldn't go to the elder daycare anymore. So because there was no more socialization, he got worse. And he got worse faster and faster, to the point where, his mental status became, in 6 months, he was not the guy I had known for a few years. So it was a rapid deterioration because he just sat alone at home watching TV, not interacting with anybody. So unfortunately, that's a very sad story, but it's not unique. The social isolation affected a lot of people in different ways. Some stories just highlight this point more than others. So yeah.
Thank you so much. Diane, do you see some more questions?
I do.
Okay.
Are you still seeing vaccine hesitancy from the Black and Brown communities? And is this happening specifically with older African Americans based on our history with the healthcare system? Or is it just misinformation?
This is the question I was eager to answer or address, because there's some fallacy behind this assertion that Black folks are more hesitant. We were definitely skeptical for good reasons, right? We have a complicated history with the healthcare system, and still continue to do so, and experience bias and racism in terms of healthcare. But actually, Black folks are on par with other folks in terms of getting vaccinated. In fact, early on, some of the other complicated reasons around seeing lower numbers among Black people, along with some concern about the vaccine or wanting more information, which rightfully we should, was access. I don't know if you saw in New York and other places where the vaccines were being distributed, and when you would look at the lines of people who'd signed up, they didn't look like Black folks, although they might be in the heart of Black communities in some of our cities. And some of that had to do with how we roll out healthcare, making it online access only, where some marginalized and disenfranchised communities might not have access. Older adults are also, not to say that older adults can't be tech savvy, but disproportionately also didn't necessarily get online in the queues to get those vaccines. So what we're seeing, actually the lowest rates of vaccination because of hesitancy are among white people. And we can imagine what some of those white groups are. So some of those folks that have drawn a line in the sand in terms of whether or not they want to get vaccinated. So Black Americans, happy to say that we have done our due diligence in terms of the scientific community. It helped very much that Dr. Kizzmekia Corbett was front and center in terms of vaccine development. We saw W. Kamau Bell and other physician scientists talking about the vaccine was safe and how clinical trials included Black folks, how we made sure that Black and brown folks were included in our clinical trials. And so we did a lot of trust building in Black communities to encourage vaccination. So just want to, be guarded in saying that, Black people are more hesitant necessarily to get vaccinated than other groups of people.
Thank you, Dr. Taylor. We are just about at the 8 o'clock hour, and before we bring in our president, Raven L. Hill of Xi Omega chapter of Alpha Kappa Alpha Sorority Incorporated, Dr. Bolo, Dr. Taylor, I would like to give you an opportunity to give some closing remarks.
Get vaccinated. And thank you for having me tonight.
Thank you. Dr. Bolo?
I'll say know your risk. The literal thing that you guys have up there, know your risk, know your numbers.
Thank you, Dr. Bolo. At this time, it is my absolute pleasure to bring in the president of Xi Omega chapter of Alpha Kappa Alpha Sorority Incorporated for closing remarks, Raven L. Hill. Hi, Raven.
Hi, Tanya, and thank you. Good evening, everyone, and thank you to our panelists, Dr. Taylor, Dr. Bolo, and our wonderful moderators, Ms. Brown and Ms. Johnson, for this informative discussion. I really believe tonight's discussion really just reinforced what we all know, and that's an ounce of prevention is worth a pound of cure. So as we've heard, know your risks, manage those risks, know your numbers, get vaccinated, get boosted, and let's all make healthier choices towards a healthier lifestyle. Thanks again, everyone, for coming, and have a great night.
Thank you.
Thank you, everyone. Have a good evening.
Have a good evening.
Thank you.
Thank you.